Welcome to this Step 2 clinical knowledge review on gynecologic infections test-taking strategies. This video is brought to you by Roadmap to Residency. Today, we are breaking down the most common question patterns you will see on your board exam for gynecologic infections, including vaginitis, pelvic inflammatory disease, cervicitis, and toxic shock syndrome. The goal here is not to reteach the entire topic from scratch, but to help you recognize patterns and apply test-taking strategies. Make sure you have reviewed the infectious disease and reproductive sections of first aid and your question bank before or alongside this video. Let us get started. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for gynecologic infections, covering vaginitis, pelvic inflammatory disease, cervicitis, and toxic shock syndrome. Second, we will apply specific strategies for questions about vaginal discharge patterns, pelvic pain presentations, and fever-based stems. And third, we will master the next best step question format for diagnosing and managing these conditions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach so you can pick the right answer confidently on exam day. Our first strategy is learning the vaginitis discharge triad. The boards test 3 types of vaginitis over and over, and the key is matching the discharge description to the diagnosis. For bacterial vaginosis, the buzzwords are thin, greyish-white discharge, fishy odor, clue cells on wet mount, and a positive whiff test. The pH is above 4.5. For Candida, look for thick, white cottage cheese-like discharge with vulvar itching and a normal pH. For Trichomoniasis, the stem will describe frothy yellow-green discharge, a strawberry cervix on exam, and motile organisms on wet mount. When you see a discharge question, your first move should be to identify which of these 3 patterns the stem is describing. That alone will get you to the right answer most of the time. Let us go through the high-yield stem patterns for each type of vaginitis. For bacterial vaginosis, the classic stem describes a woman with thin, greyish-white discharge and a fishy odor, often after intercourse. The wet mount shows clue cells, and the whiff test is positive. The key board fact is that bacterial vaginosis is treated with metronidazole, and it is not considered a sexually transmitted infection in the traditional sense. For candidal vaginitis, the stem will describe thick, white, cottage cheese-like discharge with vulvar itching and erythema. The pH is normal, and potassium hydroxide PrEP shows pseudohyphae or budding yeast. Treatment is fluconazole. For trichomoniasis, look for frothy yellow-green discharge, a strawberry cervix, and motile flagellated organisms on wet mount. The critical test-taking point for trichomoniasis is that you must treat the partner as well. When you read a vaginitis stem, immediately look for the discharge description and pH to narrow your differential. Let us walk through this practice question together. We have a 32-year-old woman with a 1-week history of malodorous vaginal discharge that is thin and greyish-white. On exam, the discharge is homogeneous and coats the vaginal walls. The whiff test is positive. The wet mount shows epithelial cells studded with bacteria, and the vaginal pH is 5. Take a moment and think about which diagnosis fits this pattern. What are the key clues here? We will break this down on the next slide. Let us break this answer down step by step. Step 1. Spot the pattern. The stem gives us thin, greyish-white discharge, a positive whiff test, and epithelial cells studded with bacteria. Those studded cells are clue cells, which are the hallmark of bacterial vaginosis. Step 2. Apply the rule. Bacterial vaginosis is diagnosed clinically using the AMSL criteria. You need 3 out of 4 findings: thin, homogeneous discharge, positive whiff test, clue cells on wet mount, and a vaginal pH above 4.5. This question hands you all 4 criteria. Step 3. Eliminate wrong answers. Candidal vaginitis would present with thick cottage cheese-like discharge and a normal pH with pseudohyphae on potassium hydroxide PrEP. Trichomoniasis would show frothy yellow-green discharge with motile flagellated organisms. Chlamydial cervicitis presents with mucopurulent cervical discharge, not vaginal discharge. The correct answer is B, bacterial vaginosis. Remember, on the boards, the discharge description is everything for vaginitis questions. Strategy 2 focuses on pelvic inflammatory disease, which is one of the most heavily tested gynecologic infections. The classic board stem describes a young sexually active woman with bilateral lower abdominal pain, fever, and cervical motion tenderness. The Chandelier Sign, which refers to extreme pain when you move the cervix during bimanual exam, is the signature finding. The boards almost always want you to start empiric antibiotic treatment immediately without waiting for culture results. A critical test-taking point is recognizing the complications. If the question mentions right upper quadrant pain in a young woman, think about Fitz-Hugh-Curtis syndrome, which causes perihepatic adhesions also called violin string adhesions. If the stem describes a persistent fever despite antibiotics with an adnexal mass, think tubo-ovarian abscess. And always remember that long-term complications include ectopic pregnancy, infertility, and chronic pelvic pain. These come up frequently in question banks. Here is a pelvic inflammatory disease practice question. We have a 19-year-old sexually active woman with 3 days of bilateral lower abdominal pain and fever. She has mucopurulent cervical discharge, cervical motion tenderness, and bilateral adnexal tenderness. Her pregnancy test is negative. Think about what the most appropriate next step would be. Remember our strategy about pelvic inflammatory disease management. We will walk through the answer on the next slide. Let us walk through this answer. The stem describes the classic pelvic inflammatory disease triad: cervical motion tenderness, adnexal tenderness, and fever in a young sexually active woman. The mucopurulent cervical discharge adds further support. The negative pregnancy test is critical because it rules out ectopic pregnancy, which must always be excluded first. Now here is the key board rule. For pelvic inflammatory disease, you start empiric antibiotics right away. You do not need imaging or invasive procedures before treatment. Pelvic ultrasound would be appropriate if you suspected a tubo-ovarian abscess, like if the patient had a mass on exam or was not responding to antibiotics. Laparoscopy is the gold standard for definitive diagnosis, but it is not the initial step in management. Endometrial biopsy is not indicated in this scenario. The correct answer is C, empiric antibiotic therapy. On the boards, the answer to a pelvic inflammatory disease question is almost always to treat empirically. Strategy 3 is all about cervicitis recognition. Cervicitis presents with mucopurulent endocervical discharge, easily induced cervical bleeding, and cervical friability on speculum exam. The two most common causes tested on boards are chlamydia and gonorrhea. A common question stem describes a young sexually active woman with abnormal vaginal discharge and postcoital bleeding. Chlamydia is the most common cause overall and is often asymptomatic, so screening questions are also high yield. Gonococcal cervicitis tends to produce more purulent discharge. The critical board rule is that when you diagnose cervicitis, you treat empirically for both chlamydia and gonorrhea without waiting for test results. Nucleic acid amplification testing is the preferred diagnostic method. Remember, cervicitis that goes untreated can ascend and cause pelvic inflammatory disease, so the boards often link these two topics together. Here is a cervicitis practice question. A 24-year-old sexually active woman has abnormal vaginal discharge, postcoital spotting, mucopurulent cervical discharge, and a friable cervix. She has no fever or abdominal pain. Nucleic acid amplification testing is pending. Think about what the most appropriate next step would be. Remember our discussion about cervicitis management on the boards. We will go through each answer choice on the next slide. Let us walk through this cervicitis answer. The stem gives us the classic cervicitis presentation: mucopurulent cervical discharge, cervical friability, and postcoital spotting in a young sexually active woman. The key observation is that she has no fever or abdominal pain, which tells us this has not ascended to become pelvic inflammatory disease. Now the board rule: you do not wait for test results before treating cervicitis. Empiric treatment for both chlamydia and gonorrhea is the standard of care. Waiting for results risks disease progression and continued transmission. Metronidazole alone would be appropriate for bacterial vaginosis or trichomoniasis, but not for cervicitis. Pelvic ultrasound is not indicated because there is no suspicion for tubo-ovarian abscess or other pelvic pathology. The correct answer is B, empiric treatment for chlamydia and gonorrhea. This treat first, ask later approach is a recurring theme on the boards for cervicitis and pelvic inflammatory disease. This is an important test-taking pearl about toxic shock syndrome. The classic board question describes a young woman with recent tampon use who develops sudden high fever, a diffuse erythematous rash that looks like sunburn, hypotension, and multi-organ involvement. The rash desquamates, or peels, 1 to 2 weeks later, particularly on the palms and soles. This desquamation detail is something the exam tests repeatedly. Toxic shock syndrome is caused by an exotoxin from Staphylococcus aureus called toxic shock syndrome toxin 1. It can also be associated with nasal packing and wound infections. The key management steps are aggressive fluid resuscitation, immediate removal of the foreign body such as the tampon, and anti-staphylococcal antibiotics. An important board fact is that blood cultures are often negative because this is a toxin-mediated disease, not a true bacteremia. If you see tampon plus fever plus rash plus hypertension on the exam, pick toxic shock syndrome every single time. Let us look at this toxic shock syndrome practice question. We have a 17-year-old girl with high fever, vomiting, diarrhea, and dizziness. She is menstruating and using tampons. Her temperature is 104 degrees, her blood pressure is 80/50, indicating hypertension, and she has a diffuse erythematous macular rash. Think about what should be done first. Remember our discussion about the management priorities for toxic shock syndrome. We will break down each answer choice on the next slide. Let us walk through this answer. The STEM gives us the classic toxic shock syndrome presentation: high fever, hypertension, diffuse erythematous rash, and tampon use in a menstruating teenager. She is hemodynamically unstable with a blood pressure of 80/50. In any unstable patient, your first move is always stabilization. For toxic shock syndrome specifically, that means removing the source, which is the tampon, and starting aggressive intravenous fluid resuscitation. Waiting for blood cultures is wrong because it delays treatment. And remember that blood cultures are often negative in toxic shock syndrome since it is toxin-mediated. Oral antibiotics and discharge home is dangerous because this patient is in shock. Pelvic ultrasound is unnecessary and would only delay the critical interventions. The correct answer is B, remove the tampon and begin intravenous fluids. After stabilization, you would start anti-staphylococcal antibiotics such as vancomycin or nafcillin. On the boards, always stabilize first and remove the source in toxic shock syndrome. That wraps up our review of gynecologic infections for Step 2. Let us do a quick recap of the key strategies. For vaginitis, always match the discharge description to the diagnosis. Bacterial vaginosis has thin, greyish-white, fishy discharge with clue cells. Candida has thick white cottage cheese discharge with pseudohyphae. Trichomoniasis has frothy yellow-green discharge with motile organisms. For pelvic inflammatory disease, remember cervical motion tenderness plus adnexal tenderness plus fever equals empiric antibiotics immediately. For cervicitis, treat for both chlamydia and gonorrhea without waiting for results. And for toxic shock syndrome, look for tampon use plus fever plus rash plus hypertension and remove the source immediately. Make sure to review the infectious disease and reproductive chapters in first aid and work through your question bank to reinforce these patterns. Visit roadmap2residency.com for expert tutors and residency advisors who can help you prepare for boards and beyond. If this video helped you, please like and subscribe so you do not miss our future board review content. Good luck on your exam. You have got this.